program coordinator for Wellcoaches membership. And if you are on the Zoom view where you see everyone, I'll just do a little wave. I'm the one who's talking to you. And so today we are here for culinary medicine and its role in restoring and maintaining health with Dr. Rani Polak. And we were just talking, if you are new to membership, or if this is a new topic for you, I would invite you to also within membership, go back, not right this minute, but later on in the week or next couple of weeks and check out other classes that Dr. Polak has presented for us, because if this is an area that you're interested in, we do have a couple other recordings in our library. And also, I'm sure that the chef coaching program is going to come up today. We will be doing a Q&A info session in August. You certainly can join that program at other times, but that's something that we do in partnership in the future. So I just wanted to throw those two things out there. But without further ado, I'm going to give you a little bit of info about Dr. Polak. But of course, as always, these are just snapshots of people's lives, and they're way more interesting than I can tell you about in the next couple of seconds. So Dr. Polak is the founding director of both the Culinary Health Care Education Fundamentals, chef, coaching program at the Institute of Lifestyle Medicine, Spalding Rehabilitation Hospital, and the Center of Lifestyle Medicine at Sheba Medical Center in Tel Aviv, as well as an assistant professor part-time at the Department of PM&R Harvard Medical School. Dr. Polak's focus, along with clinical care, is on clinical and translational research relating to the culinary coaching method, which combines culinary training with health coaching principles. Dr. Polak is the PI of the Culinary Core Group, which aimed at expanding the culinary coaching as an effective, scalable telemedicine method to improve nutrition, and a course director of a medical education program at Harvard Medical School that disseminate culinary coaching to hundreds of clinicians worldwide. That's a lot, but yeah, I'm not surprised.
Yeah. Thank you. Thank you.
You're welcome.
Yeah, and I'm also teach Wellcoaches core coach training, which is very important part of my job. So thank you for the nice introduction, and we have here as well Jane Bart from the chef coaching team. So thank you for joining us today, Jane. And I'm happy to present the field of culinary medicine, which has become bigger and bigger every time I present. So we have lots to cover. So let's just start. You're very welcome to type in questions. Either myself or Jane will take it, or I will answer questions towards the end of the talk. So what we will cover today, I will present a brief introduction to the field of culinary medicine, and then we will understand why this is so important to address home cooking, and why this is so unhealthy to consume ultra processed food, and from after setting the stage and understanding why home cooking is so important, we will discuss how culinary education can help in improving nutrition, and how you, the health coach, can help. And we will finish with a few slides about the chef coaching training. So let's start with the emerging field of culinary medicine. So I'm preaching to the choir, but just as an introduction, just to touch base and to make sure we all aware that unhealthy lifestyle behaviors account for the majority of death. And when I think about my institutions, I actually affiliated with two institutions, one in Boston and one in Tel Aviv. So each one of them has numbers of gyms with OTs and PTs that train participants and train patients how to do the right movement, how to do exercising, how to improve their physical activity level. And on the other hand, when our hospital try to help participants to improve nutrition, it stand up with only one-on-one discussion between an RD and a patient. So, my question that I asked myself about a few decades ago when my passion to culinary medicine started to evoke is why is that different? Why we are spending so much time and effort in helping patients to do the right movement, to do exercising, yet we think that only by telling them what to eat they can do it themselves. So most of the clinicians would say that something happened to my slide. Okay, most of the clinicians would say that understanding healthy nutrition is much more complicated and difficult than understanding physical activity plan, and that implementing healthy nutrition throughout the day is much more challenging than finding 1 hour or 150 minutes per week to do exercising. Yet we are not teaching people how to eat healthy. We just provide them information about what they should eat. And with this thoughts in mind and this environment, there is more and more people and more nutrition leaders that think that maybe in the same just near the gym or on the same floor of the gym, we should have a teaching kitchen. We should have a place that not only RDs but also chefs will teach patients how to cook, how to consume healthy food. And this is like the environment of where the field of culinary medicine was developed. There are a few definitions to culinary medicine. The one that I would like to present you is the definition of the American College of Preventive Medicine. And they define culinary medicine as the practice of helping patients use nutrition and good cooking habits to restore and maintain health. So let's start with reviewing the science. What we know about home cooking, what we know about ultra-processed food, and what we know about how it's so important to consume home-cooked food. So this is quite a new field, and most of the research that I will present are quite recent. And there are many groups today, including our group, that works on improving the science that we have on the impact of home cooking. So let's start with the problem. So let's start with home food preparation in the US. And you see that in the past 40 years, there is a meaningful decrease in the amount of food that people make at home. On the other side, there is an increase of the food that people consume outside of their home. So you can see that the increase is 42% and the decrease is 23%. The numbers are not really the same, but you can also see that the measurements are not the same. The first study looked at energy, the second study looked at dollars, so the numbers couldn't be the same. But you can see that the numbers are meaningful. People are eating less at home and more outside. And the next question would be, okay, why this is so important? Why this is so important if I'm consuming my food at home or outside? And this is a very interesting analysis of the Enhance. Enhance is a national survey that is disseminated every few years. And one of the questions that they ask in the Enhance questionnaire is how many home-cooked food, home-cooked dinner do you consume? Okay, not healthy dinners necessarily, just home-cooked dinners. And what they did in this study, they divided the responders to 3 groups: those who consume between 0 to 1 times per week, 2 to 5 times per week, and 6 to 7 times per week. And then they matched the average calorie consumptions to each of the groups. And you can see that, surprisingly, I would say, at least it was a surprise to me the first time that I saw this research, that as much as people consume more home-cooked food, they actually consume less calories. Just to emphasize again, they didn't measure healthy cooking. They didn't measure cooking healthy ingredients, just consuming home-cooked dinners. So then, you know, I'm a researcher, but I'm also a clinician, and then my clinician hat, you know, just raised, and I was thinking, well, it's amazing, you know, how many of my patients are trying to change their diet, are trying to avoid eating food they like, start eating food they don't necessarily like, just to cut on calories. And here, just by cooking your food, you can cut on your calories. And the next line is even more interesting, because they had another question in the enhance, if you try to lose weight. And they did a sub-analysis only to those who responded no, we do not try to lose weight. And even within this subgroup, as much as people consumed more home-cooked food, they consumed less calories. Moving on, and a very similar study from the UK. Home-cooked dinners, again, not healthy, not necessarily healthy food, not necessarily healthy cooking skills, just home-cooked dinners. They divided the group slightly different. Those who consume less than 3 dinners per week, 3 to 5 dinners per week, and over 5 dinners per week. And they looked at food groups, not only on calories. And as much as you consume more home-cooked food, you consume more fruits, you consume more vegetables. Even if you look at the overall dietary score, you can see that the diet is more aligned with the Dutch diet score and the Mediterranean diet score. This is pretty strong, you know? Consume home-cooked food and improve your nutrition. Next study is about home cooking and health. And this study is even better because they measured dinners and lunches, not only dinners. So here the total is 14, not 7. It's an analysis of 2 of the main cohorts that have ever been evaluated, the nurse health study and the health professional follow-up study. Most of the lifestyle medicine recommendations came up from these 2 cohorts from Boston. And they clearly showed that those who ate 11 to 14 meals prepared at home had lower risk of developing type 2 diabetes than those who consumed 6 meals meals at home or less. And this is most probably due to less weight gain. So those who consumed home-cooked food are more likely to consume less calories, are more likely to consume healthier food groups, and are less likely to develop type 2 diabetes and maybe other chronic diseases. So, you know, the next question would be why? Or what is the mechanism that that related to this outcome? And recently we have new science about ultra-processed food. The past 5 years, we had new measurement tools that can measure food in a very precise way about how processed it is. And researchers, including our team, are using those tools to evaluate the impact of ultra-processed food on health. So I would like to introduce you the tool and then a little bit of the science. So the tool divide the food that people consume to 4 groups. Unprocessed or minimally processed food, this is group 1. Group 2 is processed culinary ingredients. Group 3 is processed food, and Group 4 is ultra-processed food. So this is the novel food classification, and I hope you can see how innovative it is. Because it actually, I think for the first time, classified food without paying attention to the food groups. So what I mean is, I'll give you an example in Group 1. So you can see that, in the same group, you can see vegetables and beef. And when in the last time in nutrition that beef and vegetable were in the same group. So Group 1 is unprocessed or minimally processed food. So it's mostly the fruit or the vegetable or any edible part of the animal. If it's only minimally processed, it would be within this group, such as drying, crushing, and minimally processed processes like this. Group number 2, which is the processed culinary ingredients, are modified version of Group 1 that you usually consume to cook, such as sugar, salt, fat, etc. Group number 3 is processed food. Mostly combination of Group 2 and Group 1 ingredients. Usually not more than 2 or 3 ingredients. Examples include cheese, bread, canned fish, and all kind of canned fruits. Okay? And group number 4 is ultra-processed food. And again, you can see that within this group, you can see, for example, protein bars, which are, I think, considered healthy food by many clinicians and considered healthy in the public. And also hot dogs and burgers and soft drinks, same group, ultra-processed food. So those are mostly formulations that made mostly or entirely from all kind of substance that derived from food. It usually include all kind of preservative and antioxidants and all kind of stabilizer and sweeteners and items that derive from further processing of the food, such as soya proteins and high fructose corn syrup. So these are the four groups. So now let's see what happened when you try to find correlation between these food group, between this novel food classification consumption and health. BMJ, 2019. Ultra-processed food and mortality, straightforward. A higher consumption of ultra-processed food is associated with a 62% relative risk in increase for all-cause mortality. Quite strong. Almost 20,000 participants from Spain, and for each additional serving of ultra-processed food, all-cause mortality increased by almost 20%. More research, again from BMJ, 2018, ultra-processed food and cancer, 100,000 participants. Consider 10% increase in the proportion of ultra-processed food was associated with an increase in overall and breast cancer. Ultra-processed food and cardiovascular disease. Increase in the proportion of ultra-processed food is correlated with increase in cerebrovascular disease. And this study is very interesting because when I first started to read about ultra-processed food and health, I was thinking for myself, what's innovative here? I mean, what's new here? We all know that ultra-processed food is not healthy. We all know that ultra-processed food is high in saturated fat. We all know that ultra-processed food is high in sugar. We all know that it's low in fibers. We all know that it's high in sodium. This is not healthy. What's the breaking news here? So the breaking news here is that all these studies were evaluated after stratification to all of these. And you can see here very clearly that these results remain statistically significant after adjustment for all the food groups and all the nutrients that we know and think that are the connection between ultra-processed food and health. After adjustment to saturated fat, after adjustment to sodium, after adjustment to sugar, after adjustment to fibers, still there is a correlation between ultra-processed food consumption and disease. So, why is that? This is a very, very interesting study from the NIH. It was published a few years ago in Cell Metabolism. And those of you who are following research know that this is a very, very strong journal. And culinary medicine today is one of the hot topics of nutrition. So what they did, they recruited 20 patients, not only 20 patients, a very small group, but they hospitalized them to the NIH hospital for 28 days, or 4 weeks. Then they divided the 20 patients to 2 groups of 10. 10 participants who were the intervention and 10 participants were the control for 14 days. And after that, they switched between the groups. One group received ultra-processed food. One group received minimally processed food, home-cooked food, okay? What interesting was that the diet were matched for everything, for calories, for sugar, for fat, for fibers, for all the macronutrients. There was only one difference, ultra-processed food versus minimally processed food, and the participant could eat as much as they want. For the first 2 weeks, Group A was on ultra-processed food, Group B was on minimally processed food, and for the next 2 weeks, Group B was on minimally processed food and Group A was on ultra-processed food. And see what happened. In 14 days, I'm starting with this graph. In 14 days, the unprocessed food lost 1 kilo on average. With eating as much as they want, they lost 1 kilo. Okay? Those who are, and the same people, when they were on the ultra-processed food, they gained 1 kilo on average in 14 days. And when they measured the calories intake, they found that the group the people in the ultra-processed food group consume approximately on average 500 calories more than the minimally processed food. Why this happened? We don't know. One assumption that we did not talk about in this talk is food addiction. And there are researchers that believe that there is some kind of food addiction to ultra-processed food. There are today very good and validated food addiction questionnaires, and there are more and more research that show that people that consume ultra-processed food just consume more food because of some kind of food addiction. But this is only one suggested mechanism. Another very interesting potential mechanism is the fact that actually ultra-processed food include hundreds, if not thousands, of all kind of food additives and all kind of ingredients that we don't really know their health impact. Just as a reminder, ultra-processed food include trans fat. And we all, I mean, people thought until maybe 2 decades ago that trans fat is a great substitution to saturated fat. And you know, just after several years of consuming trans fat, researchers started to understand that this is totally not healthy. And this is a study that evaluated another suspect, and this is the propionate. And the propionate is a food preservative that probably most of us consume, a very, very common food preservative. And what they did in this study, they did a sub-analysis of a New England Journal of Medicine publication that was published, I think, a decade ago. And the original publication evaluated the 3 different diets: low-fat diet, low-carb diet, and Mediterranean diet. And they show the superiority of the Mediterranean diet over low-carb and low-fat. But this is unimportant. This is irrelevant to this study, because what they did, they took all the outcomes from this study, the direct study, and only looked at propionate consumption. And what they found is that propionate consumption is correlated to insulin resistance. So, you know, as much as you consume more propionate, you are more likely to gain weight and to have type 2 diabetes. And again, this is only propionate. There are hundreds, if not thousands, of material that we don't really know their impact in ultra-processed food. If you think for yourself, so what's the conclusion of all this science? What should my patient eat? I hope that you are aware of the work of Michael Pollan. If you're interested in nutrition and believe in home cooking and haven't read his book, so I highly recommend it. I think the most popular is Food Rules, and this is from Food Rules. I think that the most popular rule is eat food not too much, mostly plant. And this is another one: eat all the junk food you want as long as you cook it yourself. I think that summarized very beautifully what we know today about home cooking versus ultra-processed food consumption. So let's talk about culinary education as a strategy to improve nutrition. I mean, if this is so important and so impactful, so let's train our patients to do more home cooking. So there are more and more studies that evaluate the impact of home cooking interventions. This is very interesting because 2 systematic reviews were published, one in 2014, one in 2017. You can see from the references that the same authors publish these 2 reviews, same authors, same criteria for the review. Yet you can see that in 2017, they reviewed the science in 5 years and identified 34 studies between 1980 to 2011. They evaluated almost, actually over 30 years of research and found only 28 studies. So you can definitely see how fast this field is growing. The outcomes of the 2 systematic review are the same. We can tell quite confidently that home cooking education improve nutrition and improve knowledge and confidence to cook. There are still inconsistent health outcomes, most probably because well-designed studies are still needed. So there are a number of groups that are evaluating these days home cooking interventions in a well-designed studies. One of them is our group, the chef coaching group. And the intervention that we are evaluating is a 12-30 minutes televisit through the Zoom. And the culinary medicine program that we are delivering is following the health coaching principles. Okay. In the end of each session, people set culinary medicine goals. In the following session, at the beginning of the following session, we review the goals, and then we spend time on brainstorming about how to improve the home cooking, how to overcome barriers, how to use resources. We do include culinary training, and this is an important difference between health coaching and what we do. And we recruited 72 patients in 2 centers, one in Tel Aviv, Israel, and one in Boston, Massachusetts. And we recruited patients with BMI of 27.5 through 35. And our primary outcome was 5% weight loss. Last month, we finished the study, but the last time that we did preliminary analysis was, I think, almost a year ago. And I would like to present to you those preliminary studies, so you know how culinary medicine could be impactful. So this is the data that we had back then about the change in weight. And you can see that the average weight change at 6 months was 4.2% on average, compare then 0.2 in the control. Even though we only had 24 patients back then, the p-value was already significant, 0.008. We also had back then few participants that finished the study, that completed visit 4 at 12 months. Not many, 11, but quite a few. And you can see that the weight loss is maintained for up to 1 year. The average weight loss is 4.1 in the intervention versus 1.2 in the control. If you measure their food intake, so you can see that the intervention group consume half of the ultra-processed food compared to the control at 6 months. Okay, we are managed to help the intervention to cut on the ultra-processed food in 50%. And we believe that this is the mechanism of why the participants managed to lose weight. Our study started in 2019. You know, we used the Zoom before the COVID, before the world used Zoom, and the study finished after the COVID pandemic. So all the pandemic was part of our research without planning that. Yet we decided to see if there is any relation between home cooking and between our education to the resiliency of the participant, to the coping of the participants with the disease, and we found that the intervention group participants used self-care as the coping strategies in the disease, and we also in the pandemic, and we also found that the participants in the intervention group were more resilient through the pandemic. So, you know, to summarize the clinical or the coaching application of culinary medicine, so I think that if your patient or your client eats primarily outside or eat primarily ultra-processed food. So I think that empowering your patients to cook more at home, whatever they want to cook, is an amazing first step. Empowering your patient to cook from scratch is an amazing first step. And if your patient already cook at home, so empowering them to improve the ingredients quality or to improve their cooking techniques, I think it's a great next step. So, I hope you're all excited about the field of culinary medicine, but yet, you can ask yourself, like, amazing, but what is our role in culinary medicine? Why I'm presenting this talk specifically for you? So I think we can start from the history of our research, and I think the beginning of our research go back to 2013 or 2014, almost a decade ago, when I was a totally believer in culinary medicine and in the importance of home cooking, and I thought that home cooking education should be delivered by chefs. And for the first study that I did, I recruited people with chef certification and culinary expertise, and trained them how to work with patients. And then, we recruited through Facebook and through the Twitter, and clinicians saw the recruitment notes, and like dozens of clinicians reached out to us and said, well, we would like to join your training, and we would like to know how to work with patients to improve their home cooking. And we have a 10 years of history working with clinicians and with health coaches about this field. And we know that you guys can do an amazing job. And you don't need to be a chef in order to help people to do more home cooking. And I think that more than everybody that cooking is more than just a set of skills. It's related to many aspects that you are working with your clients. It's related to work, to family, and to personal patterns of self-care. And very basic principles of home cooking can be very helpful to patients. And this is just just an example of one basic principle that I think is the most popular principle in all the culinary medicine program that I am aware of. And this principle is batch cooking. And I think that in order to understand batch cooking, you need to think about what is the number one barrier for people to do more home cooking. And the number one barrier for people to do more home cooking in, I think, every single country that the research has been done in the country is time. Just think of yourself. What is your main barrier to do more home cooking? I imagine that at least most of you would say time. And batch cooking, the basic principle of batch cooking is when you have time to go to the kitchen, even if it's once a week, even if it's once a month, cook as much as you can in the event that you are in the kitchen, and then freeze your food or store it in your fridge and defrost it whenever you want. Here on the upper left hand side, you can see black lentils. So if you do a recipe that asks for 1 cup of black lentils, cook the whole bag. Takes the same amount of time as cooking one cup, and then freeze the leftover and defrost it whenever you need it. Here on the right hand side, you can see 2 containers of soup. Okay, cooking 4 servings of soup and cooking 8 servings of soup takes almost the same amount of time. So you can cook, if you need 4, you can cook 8, eat the 4 that you need, and freeze the other 4. Okay. And then if you're a planned individual, you can plan to eat it within 3 days or 4 days. If you are more spontaneous in food, you can just freeze it and use it whenever you want. I mean, it can be stored in the freezer for several months. And then as part of our research, we developed the definition of culinary coaching, which is the combination of culinary training and health coaching. And the fact that that you are in the best position to help patients to set home cooking goals, and you are in the best position to help them track and implement what they did. Because we want home cooking to be a behavior, not a one-time event. You can implement culinary training and culinary coaching in almost any program that you are delivering. You can implement home cooking goals in every health coaching program, and we have experience of implementing home cooking goals with all kind of programs, with even very unique populations, such as spinal cord injury population. And before I finish and take questions, 2 slides about the program, the chef coaching program. So we have a training program that train health coaches and clinicians to include culinary medicine as part of the program. It includes 2 components: chef coaching the basics and chef coaching beyond the basics. The chef coaching the basics is mostly the skills-based classes, and chef coaching beyond the basic is mostly the practice sessions. You can take the first module, you can take either live online or as enduring material. And the practice session, the second part is, of course, needs to be live. This is the certificate that you receive if you complete both components of the training. And this is how you can take the training. You can, if this is something that is interesting for you, you have here the link that will direct you to more information. And I think what we are proud of, starting this year, we are accredited by the National Board of Health and Wellness Coaching for continuing medical education. And of course, we are accredited by Wellcoaches for continuing education credits. This is the team. Jane is here, but we have more people that are helping us to do the research and to do the training programs that we deliver. We deliver around 4 live cohorts per year, in addition to the recorded cohorts that we deliver. And you know, if you want to stay in touch, you're very welcome to do so. There are many ways to stay in touch with us. We share recipes, we share publications, we share tools. You can follow us. I mean, you on my Twitter, you can follow our Facebook page, you can follow us on Instagram, on LinkedIn, in the best way that works for you. And I'm happy to take questions. Jane, do we have questions in the chat?
Can I ask a question?
Yeah, sure.
Hi, it's Elise Phillips here. Hey, great, excellent talk. I'm curious about the role of intuitive eating with the work that you're doing, and if you're doing any studies around intuitive eating with the positive aspects of home cooking and the benefits.
So we do not do any research about intuitive eating. This is a very interesting topic. It's interesting because, you know, I presented this, not this talk, but I presented the research that we do last week, and we had so many questions about if this is impactful with minorities, and this is impactful with in food deserts, And you know, so many questions, so many important questions, and you know, this field is so is really in the beginning, and the study that we did is to evaluate whether home cooking food is impactful, and I hope that within the next few months we will show that this is impactful, and then we will be able to raise more funding and to apply for more grants to work on other areas such as intuitive eating, such as working with specific populations.
Great, thank you so much.
Sure.
Rani,
Yes,
there was a question at the very beginning of your talk, so I just want to go back to that part of the chat. And it says, are there studies showing the number of calories and the quality and balance between the food groups?
Let me see if I see this question. Can you ask that again? I cannot find it.
Sure. It says, are there studies showing the number of calories and the quality and balance between the food groups?
Between the Nova 1, 2, 3, and 4?
Maybe Angela can speak up, who put the question out.
Yeah, I mean, if someone asks this question, please feel free to just ask it.
Yeah, and Helga, if you're here, you're welcome to ask your question and kind of clarify when you meant between the food groups. I'm assuming you're talking about like between the ultra processed food and the processed food, or are minimally processed, or are we not understanding your question properly?
Yes, sorry, I wrote it, and then now that I am listening, I understand why you do not understand it. As Rani is showing that there is a difference between the calories intake between home cooking and going out and have eating processed food, I would like to know if there is a study where it is also compared the quality of the nutrients between home cooking and going outside or eating processed
so this
food.
is, thank you for this question. It's a great question. This is something that we do now. This is part of the study that we do. We measure many nutrients, and we try to see whether consuming minimally processed food improve the nutrients quality of the food. We measure vitamin D in the blood. We measure vitamin C in the blood. We measuring beta carotene in the blood, and hopefully within the next year or so, we will be able to show if there is any correlation between minimally processed food consumption and blood nutrients. I'm not aware of good research that show that until today.
Thank you.
Rani, there are a couple other questions in the chat. Tara's asking, beyond batch cooking, what is the next most effective skill for clients looking to do home cooking?
So I don't know if batch cooking is the most effective. We are not in. We didn't measure specific tools and impact. I can share that this is the most popular. Like, this is what people wants to know. I think that I don't know if that's number 2, but you know, when we think about culinary medicine and home cooking skills, so we think about cooking specific food items. For example, working with legumes, working with fish, working with vegetables, and more general skills that helps you to be more efficient in the kitchen, such as batch cooking, such as and others. So I think that number 2 is repurposing, and repurposing is kind of a cousin of batch cooking, but it's not really batch cooking. It helps you to think how you can use food that you cook in a different way. For example, you know, you cook pasta dish for dinner, and then you use what's left from the pasta and making a pasta salad for your lunch tomorrow. So that would be like repurposing of the pasta that you made for, let's say, you know, pasta Alfredo for dinner, to pasta salad for the following day. What we do in the research and while we're working with patients, we try to help them to think ahead of time, and you know, when they make dinner, to think, well, what should I make more so I will be able to use it for the following lunch, and so repurposing is kind of what I have without planning, and then how can I use it, and we try to work with patients so they will plan having leftovers. A very popular skill that people ask is how to cook legumes. Very, very popular. People know that legumes is healthy, and many people do not know how to cook legumes, and many people do not know also how to work with legumes. You know, when we show people that legumes can be freeze and defrost, many are quite surprised. So these are quite helpful tools.
Catherine is asking if you can put the slide with your contact information back up. I think she missed it.
Of course.
And while you're doing that, Trish has a question about propionate. And are there specific foods that contain this? And what happens when it is consumed?
Sorry, I cannot find it.
You can't find the question?
I can't hear it.
I think we've lost your audio. I can't hear you, Rani, very well.
Sorry?
I lost your audio for a second. I couldn't hear you very well.
I'll find my earset, just one sec. Is it better?
Yeah. Do you want me to repeat that first question?
Yes,
though?
please. Yes, please.
Yeah. Trish is asking about propionate. Am I saying that properly?
Yeah.
And are there specific foods that contain that? And what happens when it's consumed?
It's very, very popular. Lots of dairy products, lots of pastries. Not specific food. We have research that show that propionate is associated with insulin resistance. This is all what we know for now.
Okay, very good. Any other questions, friends? You're welcome to unmute, or you're welcome to put it in the chat, but we also like it when you unmute and we get to see your face and ask a question.
Okay.
Right, I don't see.
I would like to make another question. I took the first part of the chef coaching training, and what I found it is that the recipes and the approach was great, but the recipes were just like for, how can I say it, not for Mexicans. I found that there were a lot of legumes, and the taste of the recipe, I think that nor me nor my clients will enjoy that much as to motivate them to change the way they cook. So I don't know if during the time you have like a more international approach, because I found that they are not only Mediterranean, but they are more like, I don't know how to say it, but more direct to certain tastes that includes a lot of lentils, a lot of beans, a lot of that peas, that kind of things. And we're missing just like fresh vegetables, like another kind of stuff. So I don't know if you have that in your recipes now, or what you think about that.
Yeah, so thank you for asking that. I'm not sure when you took the first part of the chef training, but now we have a Spanish-speaking training, and we also spend lots of time in training clinicians how to adjust recipes to all kind of cultures. But I think what most important, and this is something we are focusing on these days, is to train you how to adjust recipes, because you know, if even if the recipes were specifically to the Mexican culture, they might be, you know, they might be providers that work in cities and health coaches that work outside the cities with lower socioeconomic people. So there are so many groups and subgroups and subgroups that consume food, and this is kind of the beauty of the beauty and the challenge of culinary medicine. That I think what's most important is to know how to culturalize recipes.
Okay. Thank you, Rani.
Sure.
Thanks, Angelica. That was a great question. Any other questions? Friends, we won't hold you here if you don't have questions, but there we have time for probably one more. All right. Rani, thank you as always. Any parting words for us?
Yeah, thank you so much for inviting me, and thank you all for joining the talk. You know, if the talk inspires you to consume more home cooking, and you have an idea about how to cook tonight, about what to cook tonight, so please do so. And yeah, I hope you have a great spring.
Great. Thank you so much. Thanks, everyone. Thanks, Jane, also for
Thank
helping
you.
today.
Thank you, Jane. Thank you, Jen, for helping. Thank you, Angela, for hosting.
Sure thing. Be sure to complete your knowledge assessment. And if you have any questions, just let me know. Everybody take good care.
Bye-bye.
Bye.